Okay. Good afternoon, ladies and gentlemen. Thanks for joining APASL School e-learning seminar series 2, session 3. My name is Jimo Yang, is a friend of APASL. As you know, this series is designed to provide detailed textbook information about hepatology field during COVID-19 pandemic situation since 2020 September. Today is seventh conference. Today is a topic for HVPG, hepatovenous pressure gradient. And I introduce two moderators. One is Professor Mamun-Al-Mahtab. He's a professor of Bangabandhu Medical University of Bangladesh. And Professor Xiaolong, he is a professor of Lanzhou University of China. Professor Manum, please.
Thank you, Professor Yang, for the very kind introduction. It is my pleasure to introduce the first speaker, who is no other than Professor Carlo Merkel. Professor Carlo Merkel is a very well-known and highly acclaimed hepatologist from Italy. He is currently the Associate Professor of Internal Medicine. He heads the section of Emergency Medicine for Liver Transplantation, as well as the Hepatic Hemodynamic Laboratory at the University of Padua in Italy. His main research interests in hepatology are epidemiology, pathophysiology, diagnosis, and treatment of advanced liver diseases. He has more than 250 full papers in high-impact journals and has a high index of 49. With these brief words, I invite Professor Carlo Merkel to present the talk on HVPG and other hemodynamic parameters, principles, standardization, and procedure, and problems of measurement. Professor Carlo Merkel, please.
Well, thank you. I'll try to share the screen in order to show you the slides. And here it. Well, I think it works. Can you see the slides? Well, we can go on. Well, thank you for the presentation. And dear colleagues, first of all, let me thank the organizers for the invitation to speak on this subject that I've been involved with for many years. It's particularly important for me to speak of this topic. And let me see if it works well. And portal hypertension in cirrhosis is an important marker of severity of liver disease. And the increase in portal pressure goes in parallel with the clinical events characterizing the disease and its complication. And you see the list here in the. And the presence and the severity of portal hypertension is very relevant for the clinical course of cirrhosis. And is to a certain extent, I would say that is the leading cause responsible for the occurrence of the clinical events that characterize advanced liver disease, gastrointestinal bleeding, hepatorenal syndrome, hepatic encephalopathy, spontaneous bacterial peritonitis. All those are strictly related to portal hypertension. Well, the determinants of the increase in portal pressure in cirrhosis are increase in intrahepatic vascular resistance at sinusoidal and post-sinusoidal sites, and increase in portal blood flow. The normal values of portal pressure are 1 to 5 millimeters of mercury higher than the pressure in hepatic veins. That is 1 to 3 millimeters higher than the right atrial pressure. So normal values for HVPG is from 1 to 5 millimeters of mercury. And we consider an increase in HVPG from 6 millimeters of mercury onward, and a clinically significant increase in HVPG from 10 millimeters of mercury onward. And this will be discussed later. Portal hypertension may be assessed measuring hepatic venous pressure gradient, HVPG, that was defined around 60 years ago and progressively gained larger use in research setting, and more recently in than in a clinical practice. HVPG is obtained driving a catheter in an hepatic vein and measuring the difference between the blood pressure in occluded and the free position. In sinusoidal and post-sinusoidal hypertension, like that occur in liver cirrhosis, HVPG equals the difference between portal pressure and central venous pressure at the level of hepatic veins. And so it's an expression of portal hypertension. In this schematic view, you see the conditions of the liver in cirrhosis with the area of increasing resistance designed in gray, and you see the absence of connections between the small hepatic vein. You may see here a schematic view of the occluding catheter and the flow that is blocked, all the area in red. So the pressure is the same in all the occluded area, that is the part that is red. Therefore, the pressure we are measuring at the tip of the catheter is the same as the pressure in the sinusoid, which is high, and is the same as the portal pressure. When we deflate the balloon, blood flows freely and pressure remains that is normal, that is in this case in the hepatic vein that we measure. My talk will be dedicated particularly to the procedure, and I have divided this presentation in 5 parts of the procedure. So procedure, first of all, choice of the access to the hepatic vein. In the past, we used an anticubital vein, but it's no longer in use. The two way of access the hepatic vein may be the femoral vein or the jugular vein. Well, the femoral vein is technically more demanding because you have a tight curve necessary to enter hepatic vein. That is, in some cases it may be difficult, but obviously we can arrange this. And there is no risk of arrhythmias because we do not cross the right atrium, so this problem is not important. While the jugular vein is more recently gained more in interest, is particularly indicated in association with other procedures, in particular TIPS or liver biopsy. Here we have some risk of arrhythmias when passing the introducer across the right atrium, but this is not so a big problem. It's something that we have to take into account. Then we go ahead with the procedure, the equipment. All this investigation are done in an interventional radiology setting. We need a quartz pressure transducer that can detect changes in venous pressure. We need a recorder capable of producing a permanent tracing of pressure values at a slow recording speed, less than 5 millimeters per second. We generally use a 2.5 millimeters per second. That is 10 times slower than the recording speed of the general ECG apparatus. Obviously, we need ultrasound guidance to help for the accessing the vein. Then we calibrate the pressure transducer. So we have to obtain tracing of known pressure. We consider that a pressure of 10 millimeters of mercury is equal to 13.6 centimeters of water. So we calibrate the pressure transducer at 10 millimeters of mercury, 20 and 30 millimeters of mercury that are equal to 13.6, 27.2 and 40.8 centimeters of water. And then we place the transducer at the right atrium level. Well, now there is time to prepare the occlusion balloon catheter. We prepare the fluid to inflate the balloon. We use the contrast diluted 50% with the sterile saline because the undiluted contrast is too viscous and may obstruct the line of the balloon. It is enough of this half percent, half contrast and half saline to be seen on the images. So it is okay the same. And then we partially inflate the balloon with fluid, the line of the balloon, keeping the balloon pointing down. This we have to do many times to draw back, repeat the procedure of inflating and deflating in order to vent all air, so that the dead space of the balloon line is filled with fluid. These are the material we use for HVPG measurement, the occlusion balloon catheter. Obviously, in different countries, the different suppliers may supply different material. I'm sure that the material is more or less the same, although the makers may be different. This is one that is available for us in Italy, but I think it may be nearly the same. Then the procedure of the catheterization of the hepatic vein. We may access this of transfemoral or transjugular. The procedure is more or less the same. With ultrasound guidance, we make the puncture of the right femoral vein or of the right internal jugular vein. Then we insert the introducer, that is a French 9 size. The length is shorter, the one for the transfemoral access is 10 centimeters. When you introduce a transjugular, you have to use a much longer one. The length of 25 is used. Then on the introducer, we insert a J-tip guide wire, and on it, a Cobra tip angiographic catheter that is 5 French size. And with this, we arrive at in the hepatic vein, at the beginning of the intrahepatic vein. At this time, it is suggested to exchange the guide wire with a softer one, and the hydrophilic one is preferred to go inside of the liver of the hepatic veins. And so we exchange the guide wire with an hydrophilic one and advance it until in hepatic vein, in the place we think we have to make the measurement. At this time, we remove the angiographic catheter and leave, obviously, in the right place the guide wire. And on this guide wire, we insert the occlusion balloon catheter, that is 7 French, that we already prepared in advance, until in advanced hepatic vein. Oh, it nearly is the same, how to do the transjugular. The real difference is the length of the introducer. And I have to give you a suggestion to take into account the length of the catheters employed. Because the transfemoral access sometimes requires longer catheters. You have to consider that in many subjects, the length of 65 centimeters of the catheter, that is the conventional one, may be insufficient, and the 100 centimeters length may be required, while generally in transjugular approach, size of 65 centimeters is enough. Well, here are some images of the materials we use. You obviously, as I told you before, you can use any kind of material that is available in your hospital. You see the introducer for the transfemoral approach. You see that the introducer is shorter, while the transjugular approach for transjugular approach is much longer, as you see here. And here, these are the guide wires and the angiographic catheters we use. Well, now we are at the main point, how to measure HVPG. To obtain measurement of HVPG, the catheter is advanced in the hepatic vein. The continuous pressure recording is started. Then the balloon is inflated until occlusion of the hepatic vein. an increase in pressure value is seen. A deformation of the inflated balloon suggests adequate occlusion of the vein. Then the balloon is deflated and pressure returns to the previous value. Oh, I would say that the deformation suggests, but this not demonstrated completely, so it is necessary to demonstrate that adequate occlusion is obtained, and we inject contrast in the occluded vessels and demonstrate the absence of reflux of contrast in the hepatic vein. So it remains where it was injected. Well, so after this, after all these activities done, pressure is measured. We already measured it in occluded condition and free condition, and the difference between the two measurements is HVPG. Well, in the past years, HVPG was measured directly wedging a catheter in a small hepatic vein. And this was done for many years. I'm rather old and I remember when it was done in this way. So this is the reason why I'm speaking some words about it. Well, current guidelines are concordant that the balloon technique should be used because it is better, and we'll see why we say this. This is an example of an HVPG measurement with the balloon technique and the tracing of the pressure values. You see here the balloon inflated, the contrast that is injected with the balloon that occlude the vein, and you see that it remains in the area where it was injected. Then we deflate the balloon. Here the balloon is deflated, and the contrast flows along the hepatic vein. And you see the tracing that is low pressure, then it increases, then there is a period of plateau, and then when you deflate the balloon, the pressure returns the same as it was at the beginning. Well, a few words about the technical results. HVPG with the balloon technique has an adequate intra and inter-observed variability. It was shown many years ago. There is some data also that are personal done by us, and the inter and intra-observed variability is okay. And also, if you measure HVPG in different segments of the same liver, the reproducibility is quite good. Well, so a comparison of wedged or balloon. Well, the wedged technique was easier, was less expensive. It did not require to change the catheter and use the balloon catheter that are more expensive. But the problem is that it's less reproducible. And you see here that the variations in balloon technique are much smaller than the wedged one. So it is the main reason for this is that it's not so reproducible, because it corresponds to the value of a small area of the liver where it may be different. And while with the balloon technique, you have the value of a larger amount of liver. You see, for instance, here, we used a wedged catheter in the same segment of the same liver, but not exactly in the same place. This is this small area, where in the other, in this one, is around here. Well, these two are not exactly the same. They're not really completely different. 18 and this is 16. But you may consider that in some patient, the difference, it may be different to have a 18 or a 16 millimeters of mercury of HVPG. It may be clinically different and important. And here a comparison of wedged and balloon technique in the same subject. Here the results are not exactly the same, but rather acceptable, 20 and 21. So we can consider this more or less concordant. But I remember that in many cases, disagreements were much larger. And in many cases, are concordant, but disagreements occur and occur frequently. So clinical practice guidelines are concordant that balloon technique should be used now. Here is another example of a patient with a balloon technique inserted from the femoral vein. You see what you may expect. This is another case made with a transjugular approach. You see the catheter that comes from upper. And it's a patient who was previously treated with an embolization or collateral circulation previously. And what you see here is the same that I showed you before. You see the balloon that is clearly with the shape of the vein, is not exactly round. And this suggests that it is well fitted. And you see better in this way that the vein are clearly visible and it did not move until you deflate the balloon and the flow of the contrast goes in the hepatic vein. Well, this is the general results that you may obtain in this way. And I have a few suggestions that are important to do this procedure at best. Well, do not advance the catheter too far into the hepatic vein when measuring the free pressure, because if the catheter is opposed to the wall of the vein, the measurement is not correct. So record the tracing for 45-60 seconds to allow the measure to stabilize. You have seen in some of the tracing that the measure does not arrive immediately to the plateau, but it requires sometimes longer. So you're better to take more time. Then obtain a mean pressure and repeat measurement at least 3 times, and possibly in 2 different areas of the liver. So you see if the measurement is consistent, because it's important. Another suggestion that if the patient is pre-medicated, midazolam generally is used. There is a good experience with this. Subsequent measurement, if we have to compare previously done measurement, should be performed in the same conditions. And record ongoing events on tracing if there is cut of the movement that may produce artifact. Write on the paper, do not take care of this because they are artifacts. And obviously do not rely on digital reading that you may see on the screen. They change continuously, so you don't, it's not this the way of take your results. Criteria of adequacy. Well, consistent measurement, at least in 2 parts of the hepatic vein tree, rapid increase and decrease of pressure at inflating and deflating the balloon, and lack of reflux of contrast medium from occluded area. That is obviously important. And from this point, I have to give you an example of a pitfall. In this case, have a look at this figure. The figure is not very bright, but I hope you may see. We injected the contrast that contrasted the area, but it did not remain inside, but it flew away. And this is the beginning of this contrast that flows away. And since this is not so clearly visible, I show you a sketch that shows it better. You see that the contrast is injected, but instead, or together, it goes away and returns with a different vein. So there is a connection between small hepatic veins that makes it impossible to measure HVPG in this area. So the contrast goes away and did not remain here. This procedure, however, fortunately, we are hopeful, this was obtained regularly, cannulating a different hepatic vein. We changed the place in another place, and we were able to end this examination. And I show you another one. You see here the injection of the contrast in the sinusoids and some vessels here. And this image may appear to be an abnormal communication between small hepatic vein. No, but it is not so if you look very attention. This is an excessive injection of contrast that shows the portal vessel that feeds the occluded area that are injected against the current. They are recognized because you see the shape and the direction of these vessels, and particularly because the contrast remains in these vessels, but does not go away along the hepatic vein. So the occlusion remains at variance with the previous case. So this does not flow away. And so you have only to repeat the test, injecting the contrast in a smaller quantity, and so the phenomenon is not seen, and you have the opportunity of not making a mistake. Well, I was also asked to speak a few words on other hemodynamic parameters. It's been already a long talk, this, but if I spent a few minutes on other hemodynamic parameters, and particularly on right heart catheterization in portopulmonary hypertension. Well, the portopulmonary hypertension is a combination of portal hypertension and pulmonary arterial hypertension. It's a rare condition, is observed in end-stage liver disease, and rarely too, and more rarely, also identified in non-cirrhotic portal hypertension. Portal vein thrombosis, nodular regenerative hyperplasia, Bullard-Chiari syndrome, and so on. Well, portopulmonary hypertension is suspected when there are ECG findings of right ventricular hypertrophy, or echocardiography when there is an increase in estimated right ventricular systolic pressure. But you remain uncertain until a definite diagnosis is done. And this requires the direct measurement of pulmonary artery pressure by right heart catheterization. Well, this procedure is generally performed by cardiologists, and we do this in collaboration with cardiologists in a setting of interventional cardiology. They are a larger experience than we are in this kind of procedures, and it's better to do this together with them. Swan-Ganz thermodilution catheters are used that allow the measurement of the cardiac output, the right ventricular pressure, systolic, diastolic, and mean, and the pulmonary wedged arterial pressure that are the capillary pressure that should be normal. That is the most important point of this measurement. The catheter is advanced to right heart from the femoral or jugular vein, and the tip of the catheter advanced and dragged by the blood flow. So we have only to let him go directly where it has to go. The shape of the pressure recording allows to recognize the location of the tip of the catheter, but if necessary, but in most cases, ultrasound or fluoroscopy may be used to confirm where we are exactly. In portopulmonary hypertension, mean right ventricular pressure is high, is more than 25 millimeters of mercury, and pulmonary wedged arterial pressure is normal, less or equal to 15 millimeters of mercury. Or right atrial pressure is not important very much in this context, may be normal or elevated, according to if there are signs of vital failure, obviously. In this case, measuring this may be important, may be interesting to test vasoreactivity that helps to identify those patients likely to benefit from drugs, particularly calcium channel blockers, that are the first line treatment for this condition, may be useful to predict this activity. And here a few suggestions. Well, they are not exactly from myself, but are more from my colleagues, interventional cardiologists, that are more expert than me. Well, these are the suggestions: to withdraw diuretics the day before the examination, if is tolerable for the patient. To inflate the balloon at half its size, its maximum size, while in the right atrium. So this is better, because if you wait until you are in the pulmonary artery, it may be possible to inflate too much and make damage to the artery. It was demonstrated a few cases in which a severe damage, rupture of a pulmonary artery occurred doing this technique. So if you inflate not too much and wait until it is dropless, it goes directly in the place where it stops, it's okay, and you are not doing any damage. And second, it's essential to obtain the typical pressure tracings that are these, and not something in between these two, because results from non-typical tracing are questionable. And since the difference between a good exam and another that is not done correctly, maybe is extremely important, because this is the thing that's more important, that you measure correctly. So the general take-home messages that I give you for the end of my talk. First of all, the balloon technique should be used to measure HVPG. Second, take your time to perform the measurement correctly. Most of this activity is done in a radiology setting. And you know, our radiologists have a lot of work to do, and they are pressed by all the other doctors who ask them to do more exam and do this soon, because sometimes they need. So they press you, please be quick, because we have so many other things to do. You know, please take your time, because it's important that this measurement are made correctly. Well, take into account the criteria for adequacy, and I've ended my talk. And the clinical value of HVPG and the other hemodynamic parameters will be illustrated by the following speaker. Thank you for your attention, and I'm ended. Thank you. Well, can you hear me?
Sure.
Yeah.
Thank you, Professor Carlo, for your excellent talk. And I think it is very important because in most of countries, especially in the Asian Pacific countries, HVPG measurement is not performed routinely, especially in some rural places, because it's still invasive. So I think we still do some technical training in China. And we are happy to see in the recent years, more and more the sites could play the HVPG by themselves. Thank you very much. So let's welcome. So I think we have a couple of questions for you, but maybe we will do it together later. Okay?
Yeah.
Sure. So our next speaker is Dr. Ankur, who is presently working as the associate professor of the hepatology at the LBS New Delhi. And he's in charge of a hepatic hemodynamic lab of the LBS. And his area of interest are port hypertension, ascites, and its complications, viral hepatitis, and acute unchronic liver failure. And he has over 50 publications, leading journals, including New England Journal of Medicine, Lancet, Gut, etc. And now let's welcome the Professor Jindal for your talk. Professor Jindal, please.
Yeah, thank you, Professor Xiaolong.
How can we remove this?
I'm thankful for the organizers for inviting me for this talk. So today I will discuss about the HVPG and other hemodynamic parameters and its clinical utility in the practice of hepatology. So HVPG has stood the test of time and it remains the gold standard for diagnosing the portal hypertension, especially in patients with cirrhosis. And I will discuss over the next 20 minutes or so the applications of HVPG in clinical practice, etiology of portal hypertension, type of liver cirrhosis, the role of HVPG in patients with compensated cirrhosis, decompensated cirrhosis, patients who are planning for HVPG, hepatocellular carcinoma resection, extrahepatic surgeries, drug design and response, HVPG as surrogate markers, and finally the role of right heart catheterization, which we do often with HVPG measurement for diagnosis of portal pulmonary hypertension. So the wedge hepatic venous pressure accurately correlates linearly with the portal pressure in cirrhosis. As you can see here, the wedge hepatic pressure, venous pressure accurately correlates with the intravariceal pressure in cirrhosis. But in patient with non-cirrhotic portal hypertension, you can see here, despite the each degree increase in the intravariceal pressure is comparable with the cirrhosis. But in patients with non-cirrhotic portal hypertension, the wedge hepatic pressure is nearly normal. So in patients with extrahepatic portal venous obstruction, the intrasplenic pressure is high, the intravariceal pressure is high, but HVPG is normal. In patients with non-cirrhotic portal hypertension, you can see here there are two independent gradients, two independent site of resistance. So there is a gradient between the intrasplenic pressure and the intrahepatic pressure. Intrahepatic pressure is measured directly by placing the cannula inside the liver parenchyma, and another gradient is between the intrahepatic pressure and the wedge hepatic venous pressure. So you can see there are two types of portoanatomical site of resistance in patients with non-cirrhotic portal fibrosis. There is pre-sinusoidal portal hypertension as well as the parasinusoidal portal hypertension, which is and HVPG still remains normal in these patients, most of these patients. So HVPG is important to determine the pattern of liver fibrosis in cirrhosis. You can see here with the type of liver fibrosis, the increasing septal thickness in cirrhosis, there is higher HVPG, and the smaller nodules and thicker septa is associated with higher HVPG. So these patients with smaller nodules and thicker septa are maybe at a risk of higher decompensation and higher portal pressures. So coming on to the role of HVPG in patients with compensated cirrhosis. As you can see here, not all patients with portal hypertension has clinically significant portal hypertension. So beyond a threshold of 10 millimeter mercury of HVPG, the varices tend to start to appear. This has a very good negative predictive value. So HVPG less than 10, we hardly see any varices in patients with cirrhosis. But once the HVPG goes beyond 12, the varices tend to bleed. So bleeding is correlated with the HVPG of more than 12 millimeter of mercury. So you can see here the large prospective randomized study. We can see here those patients who are having the baseline HVPG of more than 10 remain at high risk of developing varices or variceal bleed at the follow-up of up to more than 5 years. So unlike the patient with esophageal varices, patients with gastric varices the HVPG is not a predictor of gastric variceal bleed, because almost 40% of the patients with gastric varices has portosystemic shunt, and which tend to reduce the HVPG to lower side. But the patients who have the findings of severe portal hypertensive gastropathy on endoscopy or portal colopathy on endoscopy, they tend to have the higher portal pressure, and they are the more sicker group of patients. So this was one of the classical study which have shown that the HVPG more than 10 millimeter of mercury or the clinically significant portal hypertension is a strongest predictor of clinical decomposition in cirrhosis. These patients had much higher risk of developing ascites, variceal hemorrhage, and hepatic encephalopathy. Almost 6-fold higher risk of developing these complications in these patients over a follow-up of more than 5 years. You can see here, for every millimeter increase in the HVPG in these patients of baseline HVPG more than 10, there is 11% increase in the risk of decomposition and 3% increased risk of decomposition. So in patient with compensated cirrhosis, you can see there are the MELD score is low, but there is highly variable HVPG measurement values. So HVPG is more predictive than MELD score in terms of predicting the clinical decomposition in patient with compensated cirrhosis. Not only the clinical decompensation, but the HVPG more than 10 is correlated with the increased survival in these patients as compared to those patients who are having the HVPG more than 10. So we have shown earlier in AASLD 2019 the addition of liver fibroscan measurement through transient elastography fibroscan over the HVPG. The combination of liver stiffness and HVPG, we have devised a model, and it has better predictive value in terms of predicting the clinical decomposition in patient with compensated cirrhosis. So you can see that the combination of HVPG and fibroscan is much better than the HVPG alone. So in our previous study, we have tried to define the patient with high-risk compensated cirrhosis. So these are the patients with HVPG more than 20 millimeter of mercury. These are all patients with compensated cirrhosis with baseline HVPG more than 6. So we have shown that the higher HVPG with HVPG more than 20 at baseline in patients who are having compensated cirrhosis are very high risk of having decompensation over 2 years of follow. So in these patients have almost 4.5 times of higher decompensation, and almost 44% patients with HVPG more than 20 decompensated after the follow-up of 2 years. So these are very high risk groups and called high risk compensated cirrhosis. So you can see here the HVPG more than 10 is not uncommon in patient with compensated cirrhosis. So higher HVPG, as we have shown earlier, is a predictor of poor outcome and more severe decomposition in these patients. So this study was presented in published in Lancet 2019. They have given the beta blockers in patients who are having compensated cirrhosis and HVPG of more than 10 millimeter of mercury, and they have shown that the beta blocker carvedilol or propranolol use is associated with the prevention of the decomposition in cirrhosis. So ascites reduction was there, almost 50% reduction in the incidence of ascites was noted with the use of the beta blockers in patients with compensated cirrhosis and HVPG more than 10 millimeter of mercury. So not all patients respond with beta blockers. So the site of action of beta blockers is this splanchnic vasculature. So you can see here the beta blockers mainly act against this splanchnic vasodilatation, and it reduces the splanchnic blood flow. So, but in patients with HVPG of less than 10 millimeter of mercury, there is no hyperkinetic circulation. So, major chunk of portal hypertension in these patients is due to the increased intrahepatic resistance in the liver. So, HVPG with the use of beta blockers like propranolol, the HVPG reduction is almost negligible in these patients who are having HVPG baseline less than 10 millimeter of mercury. So, the HVPG reduction is 8% only in those with baseline HVPG less than 10 millimeter mercury, but against the 16% in those with HVPG more than 10 millimeter of mercury. So, this is the reason why the non-selective beta blocker is ineffective in preventing the new varices in patients with compensated cirrhosis without varices. So in patient with compensated cirrhosis without varices, addition of timolol does not improve the HVPG much. So there is no significant reduction in the as compared to placebo with timolol in patient with compensated cirrhosis without varices. So there, this is the reason that these patients are timolol is ineffective in preventing the new varices in patient with compensated cirrhosis without varices. Moreover, the timolol is associated with the more severe side effects as compared to the placebo group. However, in those patients who achieve the HVPG reduction more than 10%, compensated cirrhosis without varices, they tend to have good prognosis. So these patients have no development of varices or no variceal bleed. So achievement of 10% reduction in HVPG in patient with compensated cirrhosis without varices may be effective in preventing the development of varices as well as the variceal bleed. And we have shown in our previous paper in GUT 2016 that the carvedilol prevents the growth of small varices. We included the patient with liver cirrhosis, mainly the compensated liver cirrhosis, with small varices, and carvedilol was more effective as compared to placebo in terms of reduction in the growth of varices from small to large varices. We have shown that the 8% reduction of portal pressure is enough to prevent the growth of varices. And not only the HVPG correlates with the presence of varices, but also the size of the varices. So larger varices tend to have higher portal pressures as compared to those patients who are having the smaller esophageal varices. So HVPG, clinically significant portal hypertension, HVPG more than 10, tend to have the higher risk of hepatocellular carcinoma, liver cancer over the prolonged follow-up, almost 6-fold higher risk of developing liver cancers. So the determination of the clinically significant portal hypertension is important because it not only prevents the development of varices, but also it predicts the development of liver clinical decompensation, ascites, encephalopathy, bleeding, as well as all development of liver cancer. So coming on to the applications of HVPG in clinical practice in patients with decompensated cirrhosis. So during the episode of acute variceal bleed, we give somatostatin, terlipressin, vasoactive agents, which not only reduces the HVPG by splanchnic vasoconstriction, but also blunt the increase in the portal pressure induced by the volume expansion, like use of excessive fluids or blood transfusions. So this was seen in the previous study that if we monitor the HVPG continuously in these patients and they reduce the pressures over the period of time within 48 hours, then these patients tend to have the controlled bleeding. And those patients who do not respond well in terms of the HVPG reduction with vasoactive agents tend to have the further bleeding and major complications and mortality. So if we see the prognostic indicators of 5-day failure to control bleed or early rebleeding or death, HVPG was the most significant variable which is associated with the failure to control bleed. Almost HVPG more than 20 millimeter of mercury is associated with almost 11-fold higher risk of failure to control bleed. So these patients tend to rebleed quite early and have poor prognosis. Other than that, the bacterial infection, active bleed at endoscopy, portal vein thrombosis, active alcoholism, and childhood stage C, class C, is associated with the higher risk of failure to control bleed. So in such high risk patients with HVPG more than 20 millimeter mercury during the episode of acute variceal bleed, the previous study have randomized these patients to beta blockers or the beta blockers versus TIPS, and they have shown that the application of TIPS in these high risk bleeders with HVPG more than 20 is associated with the lesser degree of treatment failures and lesser mortality, about both short-term mortality as well as the long-term mortality. So in these patients with acute variceal bleed with HVPG more than 20, so TIPS is a good option to prevent the rebleed, failure to control bleed, and associated with the good outcome in the long term. So how the TIPS acts? The TIPS not only cause the immediate as well as the rapid reduction in the portal pressure gradient. So this explains its clinical efficacy in terms of arresting the acute variceal bleed episode, as well as the Azygos blood flow is decreased with the use of TIPS. So Azygos blood flow is an indirect marker of the portosystemic circulation. So portosystemic collateral blood flow is decreased, as well, and this may also help in the arresting the bleeding episode in patient with cirrhosis. So even in the patient with child C cirrhosis, the portal pressure reduction with TIPS is helpful, and this has been shown to significantly improve the mortality even in the patient with child C cirrhosis. So for any therapy for portal hypertension, we need to know what is the response, how to determine the response with the available therapy. So HVPG response is defined as the less than 12 millimeter of mercury or more than 20% reduction of HVPG from baseline at 4 to 12 weeks after the first HVPG. These patients are called chronic responders. And this has been shown that these patients who are having the hemodynamic response have the decreased incidence of rebleeding, deaths, ascites, hepatorenal syndrome, and spontaneous bacterial peritonitis. In patients with compensated cirrhosis with a small varices, no varices, even the 10% reduction may be beneficial. And may be helpful clinically. In sometimes there is the patient may be lost to follow up, and to know the acute response with propranolol after 15 minutes of IV propranolol, 10% reduction of HVPG is considered significant, and it is called the acute responders. So the HVPG response has influence on the complication of cirrhosis and portal hypertension. Those patients who are non-responders have 2.8-fold higher risk of variceal rebleeding, 3.45-fold higher risk of ascites, SBP, and almost 12-fold higher mortality. So HVPG response by use of drugs is important to prevent the complications of liver cirrhosis. So, we give various therapies to prevent the rebleeding in patients with a patient who had a previous episode of acute variceal bleed. So HVPG response is most important in terms of prevention of rebleeding. So currently available drugs like the propranolol or the carvedilol may be not much effective in terms of achieving the HVPG response. The response reduction, the HVPG reduction, the responders are only 20 to 50% in most of these studies. We need more better drugs to achieve the hemodynamic response. So studies have done with the use of propranolol in carvedilol in propranolol non-responders, combination of isosorbent mononitrates with propranolol, use of statins and prazosin. These are the newer options which may be effective in achieving the more hemodynamic HVPG response and thereby decreasing the further complications of cirrhosis. And the HVPG guided therapy for variceal rebleeding is important because it improves the survival. And this is a randomized controlled trial which was published in Hepatology 2017. They have shown that those patients who were managed based on the HVPG reduction or HVPG guided change in therapy have the better overall survival as compared to control groups. So this was one of the study which was presented as an oral presentation in AASLD 2019. So once the patient developed first clinical decompensation in cirrhosis, so does HVPG has a role in preventing or predicting the second decompensation or the further decompensation in those patients who had already decompensated? So we enrolled 790 patients who had single clinical decompensation at baseline, and their baseline HVPG was recorded. And then these patients were followed up for a period of 2 years. Maximum follow-up period was 2 years. And we have shown that those patients who had the baseline HVPG of more than 20 had the higher risk of developing the second clinical decompensation. And more often the jaundice, hepatic encephalopathy, and any clinical decompensation was more significant in patients who had baseline HVPG of more than 10. Moreover, the previous study have shown that in patients with ascites as compared to no ascites had a higher HVPG, and patients who developed SBP had the more higher HVPG. So these patients are more sicker group with higher portal pressures and more complications. So in patients with acute and chronic liver failure, ACLF is basically a syndrome of acute portal hypertension. With acute insult, there is acute portal hypertension, systemic inflammation. So the higher HVPG in ACLF correlates with the more acute kidney injury, more ascites, more bleeding, and more death. So the previous study from our group have shown that in patients with ACLF, those patients who died had the higher portal pressure HVPG as compared to those who alive, 21 versus 15, and the spontaneous HVPG reduction of 3 millimeter after the improvement in the liver function correlate with the clinical improvement. So now the other complications of HVPG for clinical practice. So in patients who are fit for resection for hepatocellular carcinoma, presence of portal hypertension is associated with the higher risk of developing clinical decomposition after the hepatic resection. So those patients who have the clinical significant portal hypertension before resection have the very high risk of developing clinical decompensation. Moreover, the patients who have the HVPG more than 10 associated with bilirubin of more than 1 have the very high risk of clinical decompensation, and these patients should be selected by case-to-case basis, and it is a relative contraindication for hepatic resection in patient with cirrhosis. In patients with cirrhosis who are planned for extra hepatic surgery, baseline HVPG is prognostic. So HVPG more than 16 is very high risk, and patients who have the HVPG of more than 20 at baseline are the very high risk of clinical decomposition and complications. So in these patients, some of the studies have shown that the pre-op-TIPS in higher HVPG group may be effective in preventing the further complications of post-op as well as preventing the mortality. So HVPG has been used as the surrogate marker for outcomes in patients with use of various drugs. So in patients with directly acting agents, they have shown that after the virological achievement of SVR with the DAs in hepatitis C related cirrhosis, there is a marked reduction in the HVPG, but still still you can see here the almost 78% of these patients remain at the risk of have the HVPG of more than 10 even after the achievement of the SVR, and they are at the risk of developing clinical decomposition and hepatocellular carcinoma. So higher the baseline HVPG before the start of DA, more the risk of developing the clinically significant portal hypertension after the achievement of SVR. However, some of the studies have shown that if we follow these patients over a prolonged period of time, maybe up to 3 years or so, these patients may have the gradual reduction of HVPG over the period of time with subsequent lesser complications. So the recent study have shown that with the use of Pan-caspase inhibitor like Emricasan for 28 days shows the marked reduction of the HVPG in patients with compensated cirrhosis and portal hypertension baseline HVPG of more than 12. So this is a surrogate endpoint of clinical efficacy. Those patients who are having cirrhosis with compensated with HVPG of more than 12, Emricasan is effective in reducing the portal pressure and clinical efficacy. However, the Simtuzumab, which is a monoclonal antibody against the LOX2, is ineffective in patients with NASH-related compensated cirrhosis. There is no marked reduction in the HVPG, even after the follow-up of 2 years with the various doses of schedule of Simtuzumab. So not only we do HVPG, in the similar setting, if we advance the catheter into the heart, so we can measure the right atrial pressure, then the pulmonary artery capillary wedge pressure, as well as the pulmonary artery pressure. So these may be important in patients with cirrhosis. So we can measure the cardiac output by using the fixed formula. We can easily have the weight, height of the patient, the SpO2, and the venous saturation of the oxygen by taking the ABG from while the catheter is placed in the pulmonary circulation. Then the hemoglobin, heart rate, age, we have all these parameters. Then we can measure the cardiac output. And pulmonary vascular resistance we can easily calculate by subtracting the mean arterial pulmonary pressure from the mean capillary pulmonary wedge pressure by the cardiac output. So we can do the full pulmonary hemodynamics by simple advancing the pulmonary catheter, the HVPG catheter into the pulmonary, into the cardiac as well as the pulmonary circulation. So the portopulmonary hypertension is defined by the mean pulmonary artery pressure more than 25 millimeters of mercury, along with increased pulmonary vascular resistance of more than 3 Woods unit or 250 dynes per centimeter cube. So this is defined, both these parameters should be there to call it portopulmonary hypertension, and pulmonary capillary wedge pressure should be less than 15 millimeter of mercury, and patient need not to have cirrhosis. It may be seen even in the patients who are having the non-cirrhotic portal hypertension. So we can categorize the severity of the portopulmonary hypertension by measuring the pulmonary artery pressure. 25 to 35 is mild, up to 50 is moderate, and more than 50 is the severe portopulmonary hypertension. So by simply doing the right heart catheterization, we can easily differentiate between the hyperdynamic state, which is quite common in cirrhotics, volume overload, and portopulmonary hypertension. We can easily get to know by doing the right heart catheterization. So these are the applications of HVPG in clinical practice. We can classify portal hypertension, whether it is cirrhosis or non-cirrhotic portal hypertension, especially the patient with an NCPF or EHPVO. The fibrosis assessment, the type of fibrosis, the septal thickening, the nodule size, which may have important implication in predicting the complication. The clinically significant portal hypertension, the HVPG remains the gold standard, and this is a predictor of varices, development of ascites, encephalopathy, high risk of liver cancer, and bleeding with HVPG of more than 12 millimeters of mercury. In patient with acute variceal bleed, those with high risk group HVPG of more than 20 millimeters of mercury, TIPS may be an option to prevent the failure to control bleed as well as the mortality. So HVPG reduction with beta blocker may prevent the growth of varices. 10% reduction is enough. In primary prophylaxis, we use propranolol or carvedilol. 20% reduction are responders. However, still 50, despite best of the therapy, almost 50% of the patients remain non-responders by HVPG, and these patients are currently require EVL. For secondary prophylaxis, 20% HVPG reduction prevents rebleeding. SBP, HE, ascites, 10% reduction has been shown to be beneficial. The increased mortality in patients with decompensated cirrhosis beyond HVPG of more than 16 millimeters of mercury, and in patients who are decompensated cirrhosis planning for extra hepatic surgery, those with HVPG of more than 20 are very high risk group, and some of the studies, pre-op tips may be helpful in preventing the further complication. Thank you for the kind attention.
Thank you, Professor Jindal, for your nice talk. It is now the discussion part. I will conduct it jointly with Professor Shi. So let me bring forward a few questions that we have already received. There's one question, whether endoscopic ultrasound can be used for measurement of portal hypertension instead of HVPG. Dr. Ankur, if you may please answer. Would you prefer endoscopic ultrasound over HVPG for measurement of portal hypertension? Ankur, please unmute yourself.
Sorry. So there are a lot of studies on EOS guided portal pressure measurement, but still they are in the experimental phase and there are no large randomized studies. So currently we are using the time-tested method of HVPG by using the balloon catheter, and we found it is more reproducible. So EUS may be helpful in future in some of the difficult cases where we cannot cannulate the hepatic vein through the routine way, but still we prefer the routine method.
Thank you, Ankur. The second question is to Professor Carlo Merkel. Professor Carlo, there's a question that when do you use endovascular flow meter in your practice instead of AGPG, endovascular flow meter?
Well, flow meters, we have not a large experience in flow meters using intravascular. I remember that we tried to use them some 10 or 15 years ago when they were for the first time used in surgery, and we did it together with our surgeons. But now I think that we have the opportunity to measure the flow using ultrasound without an intravascular method, and not so many real useful information arrived from many of these measurements. So I would like to imagine what might be the real reason to measure the flow in a vessel, in which one and in which condition. Because in my view, all this, the information that we had from the use of portal pressure comes from the pressure more than the flow. So I really, in this moment, I think it might be obviously all the advancement comes from things that we did not know before. So it might be, but in my view, I cannot imagine in this moment that there may be a clinical application now.
Thank you, Professor Carlo. Ankur, would you like to comment on this, add something to Professor Carlo's comments about the use of endovascular flow meter?
No further comment, no.
Thank you.
I agree with Dr. Carlo.
Okay. And then, Ankur, there's another question to you, whether you would like to take a liver biopsy at the same time you do an AGPG.
So, not in all cases, we tend to take the transjugular liver biopsy along with HVPG. In special settings like where there is diagnostic dilemma and where there is like before in patient with severe alcoholic hepatitis and ACLF, we plan to start steroids. We need a biopsy beforehand to look for prognostication as well as before starting the therapy. So in certain special scenarios, we require the transjugular biopsies, but like in patients where we need to do only the HVPG response measurement by serial HVPG measurement over a period of time, then we do not do the transjugular biopsy. So only in certain scenarios we do it.
So Ankur, in your practice, how frequently do you do AGPG for following up the patients? What is the recommendation you follow for monitoring portal hypertension?
So in patients who supposedly came with acute variceal bleed, we measure the portal pressure. We measure the HVPG after the first endotherapy. So we measure the HVPG to determine whether this patient comes in the low risk group or high risk group. If pressures are more than 20, then these patients are at high risk of failure to control bleed and early rebleeding. And this patient, we counsel these patients for requirement of early TIPS or preemptive TIPS in these patients. Moreover, in patients with large varices or small or the high risk varices, we do the HVPG, monitor the baseline portal pressure, and then we start the drugs, the beta blockers. In our practice, we usually start with the carvedilol and then monitor the HVPG response after this period of say 3 months or so. So if the response is there, then we we are sure that these patients are hemodynamic responders and at the lower risk of further complications. If there is no further, no significant response with the HVPG, then we add on the other drugs like the statins, or we sometimes, if there is high risk varices, then we do the banding of these patients. So these are the practical applications.
Thank you, Jindal. I think I'll quit at this stage and I'll request Professor Shi to take on the rest of the discussion part. Professor Shi, please.
Okay. So one question from the audience is: do all cirrhotic patients? I think this question is for Professor Jindal. Do all cirrhotic patients require HVPG for predicting complications or response to the ASBB? Please mention the definite indications of HVPG measurement, please.
Can you repeat the question? Applications of HVPG in?
Yeah, measurement, because maybe not all of the patients need the HVPG measurement.
Yeah.
So in your center or in your experience, what kind of patient should do the HVPG measurement? Yeah,
you are quite right in the sense we are now having a lot of applications of use of non-invasive biomarkers like the liver stiffness measurement by fibroscan and the use of splenic stiffness measurement. And these all parameters are gradually replacing many of the indications of HVPG measurement in the clinical practice. But still, in some of these scenarios, like the acute variceal bleed, where we need to put in the tips in high-risk groups, and patients, the chronic hemodynamic response with beta blockers is the time-tested method to determine the clinical efficacy of beta blockers. So in these scenarios, my personal feeling is that the non-invasive measurements like the liver stiffness do not work well beyond a certain portal pressures. So in these scenarios, HVPG remains the gold standard. So I will perform the HVPG in most of the scenarios if feasible.
Okay, thank you. So the last question from our audience for Professor Carlo. So peripheral vascular resistance changes in relation to the elevated HVPG in cirrhotic patients. So do you think what's the involvement of NO and or the endothelia in that cases? Professor Carlo?
Peripheral resistance obviously is related to HVPG according if it changes during the course of the disease. Involvement of nitric oxide and endothelin should be considered in connection to all the variables that modify the tone and the response of the heart rate to it. I'm not particularly involved in this kind of measurement, and really I don't know exactly what could it be. Obviously, if you modify these mediators, the changes will be not only of this, but also of the other that works in equilibrium with them. But I'm not particularly an expert of nitric oxide and endothelin. Maybe some of the group maybe answer clearly to this question.
Okay. So Jindal, do you have any comments about this question?
Professor
Serene, please.
Question to Professor Carlo.
Yeah.
If you have a HVPG where your RA pressure, right atrial pressure is -1, -2,
if you
and
have a
IVC is 0 or 1,
if you
we
have
normally believe that this is because of dehydration. Patient has been fasting for a long time.
for too long, yeah.
So what is your interpretation when the RA pressure is in negative?
Well, it is likely that this patient is dehydrated, probably. And obviously, all these observations should be kept in mind of the general condition of the patient. If there is something like that, I would think that we should think before of making this patient in a rather normal condition and try it again, because probably some changes will be, probably this may mask some possible information that may arrive. So I think first to put more or less in the normal hydration of the patient. Otherwise, it is impossible to recognize many of the things. We are discussing on very minor changes because the numbers we are in mind are so small. They are not the arterial blood pressures.
Now, many papers are coming of the relevance of free hepatic venous pressure. Rather than wedge, many people are on the FHVP. And many times we find, especially patients with massive ascites, that free pressure is like 15 or 17 millimeters of mercury. What is your thought on a high FHVP?
Well, I imagine that if you are measuring the pressure in the abdomen, you have to consider it also this. And the real problem here is where is the 0 point? Because you have to consider that you consider the overall circulation. The 0 point is the mean pressure in the right atrium. And if you are sure that is the mean 0 value in the right atrium, the 0 you are collecting, then all the values should be higher since the blood flow on the pressure gradient. So if something is less than the right atrium, it means that the blood does not return to the heart and goes away from the right atrium. So it is impossible.
So in that patient, you will say FHVP as RA pressure. So wedge minus RA will be more correct.
I think you have to consider this as a 0 point and then consider all the other from it.
Okay. Thank you. Thank you. Very enjoyable.
Oh, can I ask you a question about the other hemodynamics parameters? Because we have a lot of questions for the HVPG, but both of the speakers, you mentioned the portal pulmonary hypertension. So actually, in China, we initiate a multi-center study this year regarding the portal pulmonary hypertensions. And my question is, in your centers, because we can measure the pulmonary artery pressure at the same time with HVPG measurement. Actually, we can do the both measurements one time because now we train our radiologist, intervention radiologist, to measure the pulmonary artery pressure with HVPG together. So my question is, in your centers, in Italian or the LBS, how many patients do you measure the two measurements together? Because we want to know the rate of pulmonary portal hypertension in decompensated cirrhosis.
Well, you're asking how many subjects with portal pulmonary hypertension we see in Italy?
Yeah.
Well, it's extremely rare in patients with advanced cirrhosis. I think we may see in our hospital 1 or 2 cases per year, and not much more of this. And they are 90%. I would say that outside of advanced liver cirrhosis for us is really an exception. I think I have seen 1 or 2 in all my activity. I've been working on this subject for 40 years, so you can imagine.
Sure, but do you measure the portal artery pressure?
For us, it's really something that is an exception. when I see one, we will show them to all our colleagues in the hospital to recognize it. This for us is really, really.
Sure. Do you know the polyartery artery?
Maybe in other countries it's more frequent, I think.
Yeah. So Jindal, any comments?
In our center, as a protocol, we always measure along with HVPG the pulmonary pressures as a protocol in all patients where we intend to do HVPG. So really the portal pulmonary hypertension is quite uncommon. We see very uncommonly, maybe once or twice in a month. Mean pulmonary artery pressure more than 25 is very uncommonly seen. So in patient with cirrhosis, sometimes the volume overload, hyperdynamic circulation may lead to falsely elevated pulmonary artery pressure. So these things should be excluded before getting the correlating the mean pulmonary arterial pressure as the cause of portal pulmonary hypertension. So in these cases, as I said, the PVR is important. Pulmonary vascular resistance calculation is quite important, because if PVR is high along with the mean arterial pressure, pulmonary pressure, then only it is called portal pulmonary hypertension.
Yeah, this the topic is very important, because 2 years ago in 2019, one of the publications in the Lancet Respiratory Medicine, they reported the drug called Merkel. Merkel can decrease the port pressure, decrease the pulmonary resistance together with HVPG. And Dr. Hemi Bosch is the co-author of that publications in the Lancet Respiratory Medicine. But in clinical practice, at least in China, we didn't diagnose the pulmonary portal pulmonary hypertension in our practice. So I think this is a very important the topic. If you measure the pulmonary artery the pressure routinely, I think it's good. So maybe you can share some published data or public data about the incidence of this disease in decompensated cirrhosis.
Thank you.
Sure. Any comments from the panel or audience? Professor Yang, Timo Yang, are you still here? Professor Ring?
Yeah.
Professor Yang here? Yeah.
Yeah. Oh, okay. Could you comment closing remark?
Sure. Maybe the more comments from audience. I pass to you.
Major nitric oxide and endosaline is just for portal hypertension. It's increased stellate cell, just one over the increased portal hypertension. So in cirrhosis, decreased nitric oxide level and increased endosaline level. It's just one mechanism of portal hypertension.
Okay.
So there is no more question. You can close the remark.
Okay, so if no more question, maybe we can close our session today. Thank you very much for Professor Carlo and Professor Jindal for your attendance. Thank you for all the panel here.
Thank you to you.